Our next speaker, Dr. Eunice Chen, is an assistant professor in psychiatry and behavioral neurosciences at the University of Chicago and director of the Adult Eating and Weight Disorders program, where she studies applications of dialectical behavior therapy to individuals with borderline personality disorder and co-occurring eating disorders, including bulimia, binge eating disorder, and more recently anorexia. Along with Deborah Safer and Christy Telch, she has authored the book Dialectical Behavior Therapy for Binge Eating and Bulimia, published by Guilford. And we had a copy of it earlier. I believe we may still, if people want to see that. It's great to have Eunice back at Yale, as her training has included 2 postdoctoral fellowships, one here with Dr. Kelly Brunell and a second with Marshall Linehan in Seattle. Please help me welcome Dr. Eunice Chen.
I'm very excited to be here and to be able to talk to you guys a little bit about the work that I'm interested in doing, that I also know that other treatment developers are doing as well. Okay, of course, that's if I can first of all work out how to press the arrows. Okay, I think we got the arrows. Okay, so what I hope to talk about today is, first of all, identifying different subgroups of folk with eating and weight disorders for whom I feel that we don't have really great treatments for. To talk to you a little bit about why in my research program we decided to utilise dialectical behaviour therapy, and also present some of this work, although it's, of course, in its very early stages. So I'm hoping, first of all, to talk about these various groups, folk who have borderline personality disorder and also eating disorders, folk who report high levels of negative affect and not just dietary restraint, a group that Heather was talking about earlier, groups of folk who are early rapid non-responders to standard treatments, and also adults with anorexia nervosa. Although after Mary's talk this morning, I also thought that trying to help folk with borderline personality disorder who are also struggling with obesity should probably be on this list, so it's not exhaustive. Carlos actually talked earlier about this, and so I don't want to review it in detail, just reviewing the different sorts of eating disorders that I'm going to talk about: bulimia nervosa, binge eating disorder, and anorexia nervosa. This is something that Heather talked about earlier, and it's really about what sort of efficacious treatments do we know are out there for individuals with eating disorders. For folk with bulimia nervosa and binge eating disorder, as Carlos and Heather have both pointed out, things are fairly hopeful because there have been multiple trials of cognitive behaviour therapy for these folk that suggest maybe roughly 50% abstinence, maybe a little bit higher for folk with binge eating disorder with this form of treatment. And this is just, a reiteration a little of what the older version of cognitive behaviour therapy is like, a 19th or so session treatment, where basically there are 3 different stages of treatment, where the first part is addressing really the behaviours by using behavioural strategies, teaching folk regular eating in order to normalise their eating, followed by more cognitive restructuring kind of techniques to help people with body image concerns, and then finally relapse prevention strategies. This is the model that underlies cognitive behaviour therapy treatment. The idea that binge eating is promoted by dietary restriction, and of course, unfortunately, binge eating then can lead to further dietary restriction or restraint and other forms of compensation. But it's been a vicious cycle that is maintained also by body image concerns and possibly low self-esteem. I also allude something that Heather brought up earlier, the sense that, in adult trials for binge eating disorder and bulimia nervosa, it is interesting to look at, who do we treat in these particular trials. Typically they are women, okay, for a start. And usually they're women not meeting other diagnoses. And I think this is often reflected in our inclusion and exclusion criteria. So, we might end up excluding people who are currently suicidal or people who have co-occurring axis 1 disorders such as substance dependence, depression, or possibly even both. And then, of course, there are some trials that actually don't say as to what exactly they do as far as inclusion, exclusion criteria. And I feel that I can say this because I'm on that list too. So, and, as Heather pointed out, I think very importantly, in these trials, over time of cognitive behaviour therapy, the older style cognitive behaviour therapy, there might be possible selection bias, and we might be missing those individuals who have multiple problems besides, say, the bulimia or the binge eating disorder, or folk who are also suicidal. And, Carlos is right in saying that the literature is very sparse on this, and there's just not very much out there. There are only suggestions, and these are the sorts of literature that are suggestive that for folk with bulimia nervosa or binge eating disorder, having a co-occurring cluster B or borderline personality disorder may mean that you have poor outcome in more traditional treatments. So the studies I've highlighted, they include Heather up there, but in the case of folk with bulimia nervosa, possibly worse outcome if they're impulsive or also meet cluster B axis 2 disorders as well. I also highlight a study by Johnson that showed that folk with bulimia nervosa and borderline personality disorder compared to folk with bulimia alone had less bulimic remission after a year of mixed psychoanalytic and cognitive behaviour therapy treatment. And the final study is by Denise Wilfley, where in one of her large trials of folk with binge eating disorder, she found that cluster B axis 2 diagnoses appeared to predict significantly greater binge eating 1 year after either cognitive behaviour therapy or interpersonal psychotherapy. So these are suggestive, but as Carlos mentioned, it's data that there's not as much out there as one would expect, and I suspect some of it's due to the lack of actual assessment of these co-occurring personality things as well in these trials. Okay, so that's one group of folk that I think, our current treatments perhaps don't do so well for. Okay, but this is another group that I alluded to earlier and briefly. It's folk who also report negative affect, and that picture dominates their presentation. There's been a lovely conversation in the literature done by Carlos Grillo and Eric Stice, which has taken a series of bulimia nervosa and binge eating disorder samples and conducted cluster analysis with these groups. Heather mentioned this, but basically these groups nicely divide into roughly a third of people who meet this negative affect subtype and the rest meeting a dietary subtype, with folk who fall into the negative affect subgroup reporting less binge purge abstinence after cognitive behaviour therapy, high rates of axis 1 and 2 disorders, such as borderline personality disorder and major depression, greater weight and shape concerns, greater social maladjustment as well. And this is a finding that's not just found with adults with bulimia nervosa and with binge eating disorder, but also in adolescents with a very different treatment, family-based treatment, also known as the Maudsley approach. So this is just an example of this kind of data, just to give you a feel, and you can see the depression inventory scores being significantly higher than being in the moderate to severe range in the group with a negative affect subtype, and in the dietary subtype, that being lower, although both of these groups have reasonably high eating disorders restraint. You can see that on the eating disorders examination restraint subscale. Okay, so moving to another group that we know our standard treatments don't work so well for, are folk who have early rapid non-response to treatment. And typically this seems to occur, or you can work this out, by the 4th treatment session. What's really interesting about this result, I think, is just that you find it across treatments for disorders. So say in the case of depression, you'll see this in cognitive behaviour therapy, you'll see this in supportive psychotherapy and pharmacotherapy. You also find this early rapid non-response phenomenon occurring across disorders, such as generalised anxiety disorder, obsessive compulsive personality disorder, alcohol abuse, panic disorder and schizophrenia. And of course, you see this in folk with bulimia nervosa and binge eating disorder. And there's been also a nice series of studies that Carlos has done here as well, where in both adult bulimia nervosa and binge eating disorder, by usually around the 4th session week, one can determine that a person might be an early rapid non-responder to that particular treatment. And again, you see this early rapid non-response phenomenon not just happening in cognitive behaviour therapy, but also in interpersonal psychotherapy, in the case of antidepressant treatment, day patient treatment, and also in adolescents, utilising family-based therapy. And this is just an example of actually Carlos's data with adults with binge eating disorder, which I think clearly shows that there's a group who respond very quickly, but there's also a group that doesn't respond so quickly, and again by the 4th session week. And this brings us to actually the final group that I would argue we don't understand very well how to treat. And this is adults with anorexia nervosa. I think it's important to recognise anorexia, highest mortality rate amongst psychiatric groups, very high death rate with long-term follow-up studies. People die not just through physical complications, but also through suicide. And, you know, a lot of people don't have good outcome to current treatments. The treatment studies are generally small. They use a smattering of different forms of psychotherapy. And I think probably one of the most interesting results in the literature is really the largest trial for adults with anorexia showed that out of 122 people who enrolled in it, that 60% of people dropped out actually of the study, which made it difficult to actually work out, you know, what treatment works with this particular group. Now, I haven't put down here, but when anorexia is complicated by borderline personality disorder, this, of course, is a subgroup of folk that I think clinicians really struggle to treat. And in fact, most of the sort of emails and calls that I might get from clinicians in the community are usually about these clients. So then the question is, the next objective of my talk was to talk a little bit about why apply dialectical behaviour therapy to these particular groups of clients. The first point is that, you know, dialectical behaviour therapy was originally designed for severe and chronic disorders, such as borderline personality disorder. And it was really developed in mind with helping people who had multiple problems and also might be struggling with being suicidal. Given this, of course, then there are certain protocols that are specifically designed to address suicidal behaviour in dialectical behaviour therapy, as well as specific protocols to deal with what we describe as therapy interfering behaviour. And that means, you know, not just clients not turning up to sessions and not doing homework, it also means therapists not turning up to sessions or engaging in therapy interfering behaviour as well. The other thing that's attractive about DBT is that, and this has been alluded to earlier, is that it's a principle-driven treatment. So many treatments will describe, you know, in session 1 you do this, session 2 you do this, session 3 to 5 you should do this, and then, you know, I think if you work you know, in a situation where you're treating somebody with multiple different problems, you can soon find yourself, you know, not following any agenda, because in a way, whatever you meant to do in session 8 is not what your client is coming along with. So DBT is characterised by being what we call principle-driven, in that, you know, what shows up in the session is what gets addressed given a certain target hierarchy. So obviously life-threatening behaviour is the highest target on the target hierarchy. Therapy interfering behaviour is the second. quality of life interfering behaviour, that might be substance abuse, it might be eating related problems, is the third on the hierarchy. And then the fourth on the hierarchy is getting to a life worth living, okay, and then finally it's client-specific goals. So basically each individual dialectical behaviour therapy session is driven by what the client brings in at that time and where that fits in that hierarchy. Another thing that's attractive about DBT, I found, was that it synthesises change and acceptance-based strategies. And so I think many treatments really work very hard at helping clients make changes in their lives or changes in the way they think, and, behaviour patterns. But, there's also things that clients, we know, they can't change. One's past, there are certain, or even one's natural propensity in terms of weight. So DBT, I think, offers strategies to teach clients and also therapists not just about change but also acceptance. Now, acceptance-based strategies, of course, include things like mindfulness. I think another thing that was attractive about DBT when I first started off this work was that it's, of course, a very comprehensive and intensive outpatient treatment. So in its original format, it's a year-long treatment that provides group skills training, individual psychotherapy, consultation team for the therapists, as well as 24-hour paging. And in DBT skills training, typically the standard dialectical behaviour therapy program will teach mindfulness, emotion regulation skills, distress tolerance skills, and interpersonal effectiveness skills. The other thing, of course, is that DBT has efficacy data. There are, I think at my last count, it was 9 randomised controlled trials for borderline personality disorder. And this includes people who are selected for being recurrently suicidal, meeting criteria for borderline personality disorder, and folk who struggle with drug dependence as well as borderline personality disorder. This research has been conducted by a variety of different teams around the world, usually involving treatment as usual or therapy by experts as a control condition. And what this research suggests is that dialectical behaviour therapy reduces target behaviours like suicidal behaviour and opiate dependence in the case of those problems. It also reduces dropout and use of inpatient and emergency services, as well as having improvements on mood and social functioning. In the case of eating disorders research, I think what was also interesting is that there's been a group at Stanford, originally led by Christy Telch and also by Deborah Safer, who over time have adapted dialectical behaviour therapy skills to be delivered for people with binge eating disorder or bulimia nervosa, but not selected for borderline personality disorder, but using 3 of the different skills that are taught in standard DBT, so particularly here mindfulness, emotion regulation and distress tolerance. This is typically offered in a 20-session treatment, and so far there are 3 RCTs, randomised controlled trials, 1 uncontrolled trial and 2 case reports. There have also been recent innovations of this particular treatment, for instance, the addition of appetite awareness. I think the other thing that's attractive about DBT and using it for folk with eating disorders has been the ease by which one can translate really the model of emotion dysregulation that is purported to underlie the maintenance of folk who are struggling with BPD behaviours like suicidal behaviour. So this is the standard model of emotion dysregulation that's taught in our dialectical behaviour therapy, where there might be a cue, say conflict with one's partner. This leads to emotion dysregulation, maybe in the form of anger, and then attempts to reduce this emotion or to avoid it by engaging in, for instance, suicidal behaviour, which, although it provides temporary relief, unfortunately can also lead to further emotion dysregulation, like shame. So that particular model, though, as you can see, is very easily translatable. You replace suicidal behaviour with binge eating or bulimia or drug use. So that's also another reason why DBT seemed quite attractive in terms of trying to develop it for folk. Okay. The other thing, of course, is that there's a theory underlying the development of borderline personality disorder, this idea that, data over time has supported just that there's a biological vulnerability to emotions, and that this, with a mismatch of environment that is experienced as invalidating, leads to pervasive emotion dysregulation. Here, meaning impulsive acts and attentional discontrol and difficulties with tolerating distress. And you can see that this model is also one that's very easily translatable to other problems such as binge eating or even substance abuse. I think the final reason why I felt DBT was a good match in trying to develop is because it's a treatment that engenders compassion also in treaters. Despite the fact that the behaviours of our clients do result in negative experiences also in therapists, and I think that in DBT there's an emphasis on not just teaching our client skills but also teaching our therapist skills. For instance, practicing non-judgment, which I think is quite helpful when you're treating clients that the behaviour is upsetting to you, as well as possibly to them. The other thing, of course, there's a therapy consultation team, and this is described, as kind of therapy for the therapist, but it's an opportunity for therapists to also practice some of the skills that they teach their clients. So this was another thing that makes this particular treatment attractive for further treatment development. Now, I've added this slide here because I just want to put into context the sort of work that I'm interested in. But also I'm hoping it might encourage others to also gather data as well, people who treat clients in the community. There are different forms of treatment development. Stage one of developing a treatment is often just trying to work out, is it feasible for the group of people that you want to develop the treatment for? And often this involves putting together a treatment manual, and this might take, multiple iterations of case series. It might involve small randomised controlled pilot studies, or it might involve single subject experimental design, those ABA kind of studies, getting no treatment, getting a bit of treatment, and then getting no treatment and seeing the outcome. In stage one, it also involves trying to work out how do you train your therapists, okay, and what measures should you provide to assess outcome in your studies. So most of my studies that I'm going to talk to you guys about here are really kind of stage one studies. But I always present this slide because, I sort of think, well, if I can do it, I think other people who treat clients can also probably gather some of the sort of data that I'm going to talk about. Of course, there are also stage two studies, which are more validation studies of efficacy. And these are your standard randomised controlled trials compared to, say, control treatment, and it might be like a standard treatment. It might involve replication studies or studies that examine the mechanisms of treatment. What are the mediators and moderators of a particular treatment? And then finally, there's stage three studies. These are dissemination or effectiveness studies where the goal is to work out, how do we do this treatment that's gone through, stage one, stage two development process? How do we do it in the real world? Okay. And how do we evaluate that? And then how do we look at things like cost effectiveness? Okay. So, so the first group that I described, so folk who have eating disorders that also have borderline personality disorder, we got interested in this group because some of the data that had been reported, and also because of looking at Marshall Linehan's data, that's suggestive that, even though there's DBT, and DBT makes a great difference for folk with borderline personality disorder, there's some suggestion that possibly, at least in a treatment-seeking sample, and here I'm talking about Linehan's studies combined, what we saw in her sample is just that folk with anorexia nervosa or bulimia nervosa who also had borderline personality disorder, when they're compared to people who have borderline personality disorder without eating disorders, this seems to be associated with greater risk of recurrent suicidal behaviour and self-injury. And in particular, for anorexia, recurrent suicidal behaviour, and in the case of bulimia, particularly recurrent self-injury. So that was an interesting thing to note in her sample. In fact, it's about, I think, 18 times more likely, it's the other way around. Bulimia is associated with suicide attempts and anorexia with self-injury. But it was the risk was quite elevated. Of course, this could be anomalous statistical finding and it needs to be replicated, but we did find this curious. The other thing that we found curious was that people with anorexia and also binge eating disorder who also had borderline personality disorder, when you compare them to folk with borderline personality disorder without eating disorders, this seemed to be associated with greater comorbidity of other non-eating disorder axis 1 disorders. Again, we don't really understand, why is this so, and it's a descriptive study. I'm hoping that other people will look at this in treatment samples as well to give us a sense of, is this a true finding or is it more like something that happened with the stats? But we do find it interesting. The other thing that we've done is to have a look at, with Marsha's group, is combining 4 of her published dialectical behaviour therapy randomised controlled trials and looking to see, what are predictors of outcome in dialectical behaviour therapy for people with borderline personality disorder. And the results suggest that current and lifetime eating disorders might be quite important in predicting outcome in dialectical behaviour therapy. And remember again, this is a treatment-seeking sample, so it's different from Carlos presented earlier, for instance, a naturalistic followed-up sample. But Carlos, correct me if I'm wrong. But that's, I think, an important caveat to add. But what this suggested was that having a current eating disorder seemed to predict no remission from borderline personality disorder, and that current eating disorders and a greater length of hospitalisation predicted suicide attempts. And then finally, that a lifetime eating disorder, together with greater number of psychiatric admissions, plus higher income and younger age, seem to predict non-suicidal self-injury in terms of outcome. So in other words, poorer outcome with that particular group. So for some reason that we can't particularly understand, and in Marsha Linehan's sample, so this is not everyone's treatment sample and it needs to be replicated, there seems to be some sort of thing about eating disorders not necessarily predicting better outcome in folk who have borderline personality disorder. So of course this makes it important then, I think, to try to work out how to help folk with borderline personality disorder who also have bulimia nervosa or binge eating disorder better. And, I'm just going to give you a little example of a study that we did, which is an example of a stage 1 study. This was a case series study of folk who had bulimia nervosa or binge eating disorder and also met criteria for borderline personality disorder. They received 6 months of, I would say, very minimally adapted standard dialectical behaviour therapy. And just in our typical, Linehan's lab's typical procedure, which is, pre-treatment, assessment, 6 months of treatment, followed by end of treatment, followed by 6 months follow-up. And I think there's nothing particular to note about the sample other than, we specifically chose people who had a history of suicide attempt, and you can see that everybody had outpatient treatment in the past, but half of them had it just in that last year, with quite a few people also receiving services for suicidal behaviour and non-suicidal self-injury. In terms of treatment adaptation, as I said, there wasn't actually that much adaptation, but they may have been important enough to make a difference in some ways. So, for instance, really targeting binge eating, okay, and seeing it as part of emotionally dysregulated behaviour. But then I think that case series definitely taught me a lot about trying to think about binge eating within the context of the dialectical behaviour therapy target hierarchy, because, you know, there was a dilemma when we first started this work to work out whether the eating disorder behaviour, here the bulimia nervosa or the binge eating behaviour, should be something that is higher up on the target hierarchy list, because of course it would typically be argued to be a quality of life behaviour. And then of course, you know, a lot of the clients, it was trying to work out, well, you know, should one prioritise one quality of life behaviour over another? Because if you're struggling with binging and vomiting, but also illicit drugs, both of which one could argue quality of life interfering behaviours, is kind of tricky. So in the end, though, we did keep both, say, drug and also eating behaviours as quality of life behaviour. But, you know, dialectical behaviour therapy does allow you to work out, given what the client's presenting with, you know, whereabouts in the hierarchy you want to treat the problem. So, for instance, if someone had come in with very low weight and also were binging and vomiting, and that their low weight meant that they were medically unstable, that might result in that behaviour, binging and vomiting, being treated as life-threatening behaviour. And, of course, I think those of you out there who work with trying to help people with borderline personality disorder, they were trying to work out, you know, which target to go for, because there are always multiple, and which quality of life target. And it really helped to go back and actually read what Marsh had written in her original book, and really how to work out how to prioritise quality of life targets, considering things like how immediate the problem was, you know, working on the easy problems before the difficult ones, and also working out what behaviours functionally are related to higher targets. And I think finally, making sure that you're working not on just what the researcher or the therapist wanted to work on, but what the client wanted to work on. We had some minor adaptations to structure, as you can see, 6 months of treatment, slight modification, obviously, of skills for binge eating, and, you know, we didn't actually add an eating disorders module or chain analyses, particularly for binge eating or bulimia, in group skills. We did try to do an adjustable 24-hour rule for binge eating. I know Lucine will talk more. She does this sort of thing too, but slightly differently, but she'll talk more about this. I think another thing that we really realised was, you know, mainly if you do DBT, if you're going to work with eating disorders clients, you actually have to really know and understand a lot about eating disorders. So that was another training thing that we noticed was important. Okay, and so these were the results of this particular little study that just generally suggested, you know, large effect sizes for the eating behaviour and social functioning, medium effect sizes, self-injury and suicidal behaviour, and none eating disorder axis 1 problems at the end of treatment, but by follow-up, our effect size did get larger. But, you know, you've also got to recognise the limitations. This is a small sample. It's a case series rather than a randomised controlled design. The follow-up was short-term. It was conducted in a highly specialised eating disorder clinic. A highly specialised DBT, borderline personality disorder clinic. And it didn't include clients with anorexia nervosa. Okay, I'm looking at the time, and I know technically I've probably got 5 minutes or so. But basically, this is one of the other little studies that we are in the process of completing follow-up for, and that is selecting women with bulimia nervosa and who also have high levels of negative affect, and developing dialectical behaviour therapy for these folk compared to a pharmacotherapy treatment. That's our sample at this point. And then this is another sort of study that we're very we're trying to develop DBT for, and that's folk who are early rapid non-responders, who have binge eating disorder and who've gone through a protocol of 4 sessions of individual behaviour therapy before being randomised to standard dialectical behaviour therapy or cognitive behaviour therapy enhanced with the caveat of not including the focus component, so in other words, just the broad component. And in this particular trial, we're very interested in the psychophysiological, or possible psychophysiological moderators and mediators of these treatments. Okay. And then finally, I just wanted to briefly talk about developing dialectical behaviour therapy for anorexia nervosa, because I think this is a good match for the disorder, even though one could argue it's on the other spectrum of being, folk who are more emotionally constricted. But DBT does teaches therapists certain strategies to deal with ambivalence that clients with anorexia might have about treatment, as well as skills to teach clients to deal with the emotional behavioural avoidance that you'll see in anorexia, as well as the high anxiety. It also has protocols to address suicidal behaviour, and I think importantly engenders compassion in clients and therapists, because sometimes anorexia nervosa behaviours can seem, for instance, be regarded as manipulative, for instance. But, we've done a very small case series with folk, the majority who were vomiting or purging when they came to treatment. They're all female, age range from 20 to 47, the length of time having anorexia being from 7 up to 20 years, with a series of different sorts of medical comorbidities and psychological comorbidities. We administered standard DBT with these folk, and we get a medium effect size for this particular outcome measure. But you can see, I just wanted to describe to folk what a stage 1 treatment development program looks like, because we have to go on and do more work following iterations. Our goal is to try to do more iterations of this treatment, but at each time with additions and changes in the manual that we're using. I think our new iteration, what we're trying to focus on is adding a radical openness skills module that Tom Lynch has developed for emotionally constricted disorders that is particularly targeted at the perfectionism and the cognitive inflexibility that one might see in anorexia. Okay, and that gives you some ideas about the length of treatment and the kind of body mass indexes of folk in our first case series. You can see we've got more work to do. But, finally, I think challenges. I think, there are many challenges to work on, but I do think treatment of chronic adult anorexia nervosa clients, trying to also understand this relationship with borderline personality disorder, how to help people engage and stay in treatment. These are, I think, important treatment development goals. Trying to work out, what sort of targets are there for change and also for acceptance, and not just for clients, also for therapists, with working with folk who have, chronic histories of anorexia nervosa. I think another thing that's actually very important for treatment development researchers to work on is trying to understand the mechanisms of action of our various treatments for eating disorders and, say, borderline personality disorder. What is it that mediates treatment? Is it skills use? Is it the reduction in things like experiential avoidance? I think that, this is actually really important and might involve sometimes going back to much more basic research. I don't have here, but, for instance, dialectical behaviour therapy, as Carlos pointed out, is one of a new wave of behaviour therapies, and they're all actually typified by approach to cognition, which involves teaching clients mindfulness strategies in some way. But, people like Richie Davidson are trying to understand, what's happening in the brain when one practices mindfulness. And I think that in some ways we have to go back to try to understand, the strategies that we teach our clients, what actual effects are they having, before we then necessarily add them to a huge treatment. But I think that Carlos's comment, which is also a challenge, I think, to treatment developers, and an important one, is really trying to think about, there's one sort of approach to treatment development, which is, a top-down sort of approach, that is, give all the treatment you can possibly give, to someone. And the other approach is also to try to work out from the bottom up, what sorts of strategies in treatment work and are the most efficient to deliver people. But I think probably both of these things have to go hand in hand. It's a dialectic for treatment developers, I'm sure. And then, of course, thinking through combining dialectical behaviour therapy with cognitive behaviour therapy techniques is another thing. Now, I do want to also just add, what I talked about was, developing dialectical behaviour therapy for folk whom we don't have so great answers for, who have eating disorders. But I talked about it from the standpoint of DBT, and I wanted to add, this is not the only treatment. There are many treatments out there. The role of treatment developers is to help clients, ultimately, and, if there are more treatments out there, all the better. So yes. Thank you.
Thank you, Dr. Chen. We now have time for questions, and I see at least one over there to get us started. Thank you. And we have it's IPP has evidence, also integrated cognitive approach. Why leave out interpersonal, the module? Why do leave that out?
Oh, yes, that's a very good question. So in the Stanford adaptation of dialectical behaviour therapy for bulimia nervosa and binge eating disorder, you probably observed that it teaches 3 skills: mindfulness, emotion regulation, distress tolerance, but it doesn't include the interpersonal effectiveness set of skills. And actually the main reason why was for research reasons. They were, I think, thinking of comparing it to interpersonal psychotherapy at some point, so they needed to make sure that the 2 treatments, if they were going to do it in a randomised controlled trial fashion, that they weren't overlapping. So that's what's done in, the research studies. But in real life, obviously interpersonal effectiveness skills can be very helpful for folk who are struggling with eating disorders. So I would suggest, if you're practicing clinically, don't hold back from doing those particular skills or teaching those skills.
We have a question about whether you have a sample diary card where eating disorders are the target behaviors. I don't know if you have that. There's more question here, but anything on any way that you would adjust the diary card for eating disorders?
For the Stanford adaptation, there is, actually, I suspect Lucine might have. Oh, Lucine's nodding. Lucine will show you a diary, but I think if you're interested, you can also look in Christy and Deborah's book, because you'll see that it's got an example of a diary card.
Okay. And then we have a question about were eating disorder clients in skills groups with non-eating disorder clients, and this person shares experience about it being important to model healthy snacks as part of the skills groups, discuss how emotional relations affected by foods. Were there any tweaking to any skills related to this? And they mentioned the please master skills from DBT. I hope I got the question right. If I understand, I think the question is first, would you put patients in mixed skills groups, and second, would there be any specific protocols around food in the skills groups? I think that's the focus.
Yes. Okay. So in Linehan's program, when we did that case series, we did have mixed eating disorders and folk who didn't have eating disorders in that group as well. So yes, you can do it. I run an eating disorders program though, so pretty much everybody who's in my DBT skills group has an eating disorder. So it can be done. The second thing is, in terms of snacks, the thing about snacks is that, and for eating disorder clients, it's learning how do you negotiate food? So it actually becomes a great opportunity to practice skills.
Okay. We have a question that involves looking at patients with both eating disorder issues and substance use, and referring to an underlying personality traits that precede both of these sorts of disorders, and how would DBT address the underlying issues beneath these behaviors?
This might be someone who meets criteria for borderline personality disorders.
I believe the intention of the question is that there may be a personality style that leads to addictive behaviors, whether that's food or substance, and does DBT address such things?
That's a good question. And I'm sorry if I don't understand the question well enough in my answer, but in DBT, I guess we would be, addressing both of those behaviours. And in terms of underlying personality, there are secondary targets, and I don't know if Lucy might talk more about this. Lucy's shaking her head and saying no. That one might address some of these things in terms of personality. But remember, think through the targets, because you can see, okay, there might be certain personality things that might be underlying, but there might be, therefore, certain behaviours, quality of life behaviours, that result from that, and that you might end up targeting it in that sort of fashion. I hope that's helpful.
Okay. There's a question here. This may have come up when I was out of the room. It's, what is the dialectical strategy metaphor of the Olympian? Did that get mentioned? I think I stepped out. I think I missed this as well, so I'd like to hear it as well.
And you didn't miss it, because I think I skipped through it because I was worried I was running through out of time.
Is that in the handouts?
Yes, it is in the handouts, and so yeah, thank you for asking. It allows me to give that slide. But that refers to something that's taught in an adaptation in DBT for bulimia nervosa or binge eating disorder, where basically it's taken from dialectical behaviour therapy for substance dependence, where basically we teach our clients that really the goal is to head for abstinence for binge eating, okay? But like any Olympian who you're focused on getting the gold, okay? You're not running to get the silver or the bronze, okay? There's always in the back of your mind, what should happen should I fall, okay? So it's teaching clients that, yes, the goal is heading towards binge eating abstinence, okay? But at the same time, being prepared for falling. In other words, slipping and binging.
Thank you. We have some questions in the balcony from David.
Yes. Someone was wondering if you could share your thoughts on DBT to treat adolescents with anorexia nervosa and with borderline personality symptoms.
Oh, I think that's a great idea. I hope someone's doing this. I think it's really important, because we know that a lot of eating disorders start early, and as Carlos pointed out, the earlier the intervention, the better the chances of outcome. And we know that also with borderline personality disorder, it starts earlier, and some of the symptoms start earlier. So if one can intervene early, this, I think, makes it a lot less likely that people will suffer. So that's a great idea.
And just one more question. Someone else wanted to know, what are your personal thoughts on the use of medication and treatment with these patients that you've been working with?
Well, I've got to say, I think I was looking at some recent review, and I think it wasn't very hopeful about the use for pharmacotherapy for borderline personality disorder. So I was like a little demoralised. But at the same time, I also know that for many folk, medication has been helpful. But as also Mary pointed out, there are also side effects of these medications that, we're starting to understand a little bit more about, that, mean that they have to be, if they're used, to be used with caution. I don't know if I gave you a great answer, but...
Thank you.
Thank you, Dr. Chen.
Thank you.